Good afternoon, and welcome to our healthcare reform panel. My name is Dan Witherow with UC Davis. We have several panelists who are going to talk to us today about healthcare reform. We have representatives from several counties. What we're going to do is we're going to have each of them come up, make a presentation, tell you about healthcare reform in general and specifically in their counties. And then at the end of the session, we'll have a Q&A session, give you an opportunity to ask all of our panelists questions about how they're approaching healthcare reform. Okay. Our one housekeeping measure, I forgot, Cesar gave me stuff to do. We are videotaping this panel, so if you have to get up during the presentation, you've got an urgent call. Try not to stand up in front of the camera if you can. That would be great. Other than that, sit tight, and here we go. Our first presenter is going to be Kathy Senderling McDonald. Kathy is the Deputy Executive Director for the County Welfare Directors Association of California. In that role, she works with the association's Executive Director and the Human Services Directors of all 58 California counties. She promotes legislative budget and policy changes that improve health and human services programs and the delivery of those services. Kathy.
Great. Hi, Kathy. Hi, everyone. So thanks so much. I really appreciate everyone being here today for this presentation and this panel. Obviously, interest is high in healthcare reform, and I have a lot of familiar faces that I've recognized and some new ones too, of course. I did speak I think it was 2 years ago in Monterey, right after the health reform law was passed, and we were just sort of sorting out what it meant. And so I've got some refreshers for you, as well as some kind of looking ahead and thinking about next steps. So as a little overview of the presentation, like I said, I want to just give a refresher about some of the items that are actually in the Affordable Care Act and some of the subsequent regulations. Talk a little bit about the Supreme Court and what their decision meant for the Affordable Care Act and for states. Give some enrollment projections and a timeline so you know kind of what we're looking at having happen here in 2013 as we head toward the full implementation in 2014. I've got some status updates for everybody on the Department of Healthcare Services work, the health exchange work, and the legislature and what's going to be going on this year with those processes. There are some specific proposals in the governor's budget that I thought you would be interested in learning more about. And then to the meat of it, thinking about the role of county eligibility workers and county human services departments in the implementation. At a high level, you're going to be hearing from the rest of the panel very specific information about what they're thinking locally that I think will help spur your thinking as well. And then finally, just touch a little bit on horizontal integration. And if you don't know what that is, I promise to explain that. And then questions, of course, at the end after all the panelists. So a little bit of a refresher. So the Affordable Care Act, as you recall, passed in 2010 at the federal level, and it includes a number of private insurance market reforms that are in place already. If your kids, for example, are still on your health plan up to age 26, woohoo, and that's because of the Affordable Care Act. That was something that took effect very quickly. The things that really affect us professionally, the coverage expansions, the individual mandate that is going to drive people to seek that coverage, they don't take effect until January 2014. And then there's the Medicaid expansion. Sort of the two big pieces for us are this Medicaid expansion and then thinking about the exchange-based coverage. The Medicaid expansion is going to go up to 138% of the federal poverty level. What that is, it's 133% plus a 5% deduction that everyone will get. So deductions like we have today, all the different little cats and dogs deductions for child care expenses or medical expenses, they've essentially rolled all of those into one 5% deduction, and that's what brings it up to 138 as the cutoff for the new Medicaid program. And really, the group that this is aimed at that does not get coverage today under Medi-Cal is those childless, non-disabled, non-elderly adults, the people today who go into your county indigent programs or for whom you just have to say, I'm sorry, there's not anything available for you. It does affect parents and children as well. Coverage for them is going to become simpler, and they are going to be covered under some of the changes that I'll get into in a little bit more detail on subsequent slides. But important to remember that in addition to this expansion, there's a lot of simplifications to the program too. In particular, eliminating the asset test and some other changes that I'll get into as well. And then the other piece, the other big piece for us, again, professionally, is the exchange-based coverage. And that's aimed at people really up between 138 and 400% of poverty. Very similar to the private market, thinking about private insurance products that would be available through state or federally run exchanges. In California, we will have a state-run exchange. We've already got that established, and I'll talk a bit about it. And then in order to help people pay for that coverage, there are subsidies in the form of tax credits up to 400% of poverty. People who are over 400% could still buy insurance through the exchange. Just as you might go to an insurance broker today, there would be no subsidies for them is the key. So those are the two big pieces that I'm going to kind of drill down a little bit into today. So I wanted to just remind everybody about the Supreme Court. They ruled since the last time I think you all got together, it was in 2012. And what they said was that the individual mandate, the requirement that everyone have insurance, as long as there are affordable coverage, there are some affordability provisions. So if coverage is just considered to be way too expensive for someone, they can opt out and they won't get penalized for that. But other than that, you need to have insurance either provided by your employer or you need to purchase that. And there would be fines that are administered through the IRS and the tax structure if you don't. So that was the part that people were really worried. They thought the Supreme Court might strike down. And if you don't have a requirement to have coverage, would people really come to these exchanges or come sign up for this new expanded Medi-Cal program? But in this case, the Supreme Court said, okay, the individual mandate is fine. We're good with it. They did not strike it down. They upheld it. However, in a surprise move, they partially struck down the Medicaid expansion requirements. And essentially what they said was that the federal government couldn't threaten states with taking all of the federal money that they get for Medicaid if they didn't do this expansion. That had been the stick. There was a carrot, which was we'll give you 100% funding for the new people, but the stick was, and if you don't do it, we're going to take all of your Medicaid money. The Supreme Court said some threat is okay, but this was too much. They didn't draw a line of if they'd said half or a quarter of it, how much could you have said and what would the threat have been and been allowable. But they said we know that threatening all the money getting pulled is too much. And so essentially that really affects the expansion for childless, non-disabled, and non-elderly adults. And the federal government came along behind the Supreme Court ruling and told states, you can't do this partially and still expect us to pay for it. If you want to go part way, we need to do that via a waiver, and you'll get the regular 50-50 federal funding. If you want us to foot the bill for all of these new people, you have to go the whole way. So you can't have it's kind of all or nothing. California, interestingly, is looking to expand. The conversations are around doing this expansion, but we have not yet enacted the legislation that would be necessary to actually take advantage of this expansion. So that's something that we'll be watching, and I'll talk a little bit more about in the presentation. So continuing the little refresher here, you're going to hear the word MAGI thrown around a lot. It stands for Modified Adjusted Gross Income. And what that is, it's the adjusted gross income as determined under federal tax rules, plus any foreign or tax-exempt interest that someone has received. Probably a lot of the folks that we see today have not received foreign income, but it happens. But it's all going to be very based on the taxes filed, the income for tax purposes versus a pay stub and the types of things that we're used to getting verification of income about today. It's also going to change how the households are structured. Similar to basing the income on how the taxes are filed for someone, the household is going to be also based on their tax filing status. So today you might have people who are living together in the same household, but they're not on each other's tax returns, but you consider them a household for purposes of Medi-Cal eligibility. In this case, households are that might be two households for purposes of this new program. And so that obviously, once those rules are changed and how we structure people's households, there's going to be some training and some changes around that everyone will want to know about. It's also, I think, likely because of this that households are going to likely be smaller on average than they were. If people need to be claimed on each other's taxes, then you might have multiple smaller households living under the same roof versus today if you would count them all together in one unit. For existing enrollees, people who are today on Medi-Cal who would be potentially subject to these new rules, parents and children, for example, going forward, there's not going to be an asset test. Well, when does that happen? It's going to happen at their next annual renewal. And so until then, they stay in the same Medi-Cal program, unless, of course, they become ineligible, which I don't think that precludes us from making eligibility-related changes. But the rules for renewal are going to change. They're going to be simpler, I say optimistically, because the process is still in development. So the main difference to know about is today where the packet goes out to them and it's blank, and you say, fill it in, tell us what you've got going on, what changed. The idea would be to take a look at available information and see if we think they are still eligible. And so instead of saying, we'll not even determine if you're eligible for the coming year until you give us the information, we'll look at the information. We think that you're eligible. Here's what we base that on. If we're wrong, let us know. And if we don't hear from you, your coverage is going to continue. So you may not hear back and get a packet back from everyone because people who think you use the right information, they just won't need to send anything back. That is a very high level of a process that is obviously going to change a lot of things that you do today, and so something to be very aware of changes coming down the line. And then there's still going to be some people who are eligible under the old rules, and this is referred to as non-Magi Medi-Cal. An example would be people who are eligible on the basis of a disability. That was not changing. That was left out. There's still an asset test, and so there's some underlying program categories that are going to stick around, and counties will continue to have actually sole responsibility for all of that non-Magi-based coverage. So the Affordable Care Act also requires a single streamlined application for all health coverage programs. That's going to necessitate a reworking of the current applications, which are, I think you'd agree, anything but streamlined. And the county systems, your computer systems, as well as the online application systems will also need to be updated to reflect what hopefully will be a simpler set of data elements that you're asking someone for when they are applying. In addition, there's going to be a new online portal. I want to make sure it's understood that this is not replacing the county's online systems. Your online systems that exist today through LEADER and CalWIN and C4 allow people to do more. They can submit reports, they do CalFresh and CalWorks, and this new online portal that they're creating for the health coverage programs is focused primarily on the exchange, with interest in having people sign up for Medi-Cal, but it's not intended to replace the portals. It won't have CalFresh, it won't have CalWorks applications, so it will not, it's not intended to just come up on day one and then your stuff just goes away. There's a recognition that the current systems got built up to do more than what this new system is gonna do. But this new system will be the official portal of our California exchange. And what they're really trying to do, and you'll see, I think, as you look at their websites and things that they're going to be bringing up in the next several months, they're really encouraging self-service. Try to do it for yourself. Go online for yourself. Report to us online if there's a change in your system. Here you can go on and do your annual renewal duty and that sort of thing. So we'll really see that geared as your systems are gearing to try to allow people to really go on and do it themselves. So how many people are we talking about in these new expansions? For Medi-Cal, the new eligibles, this is the group that today is not eligible and would be a part of that expansion population, assuming the state does go ahead and enact legislation to do it. It's estimated that there would be more than 1.4 million people out there who would be newly eligible. That's not the take-up rate. That's assumed to be a bit lower. By 2019, sort of the steady state that they're thinking is between 750 and 910,000 people enrolled in that group at any given point in time. Now, existing folks, remember there's people out there today who are eligible but they're not enrolled. That's estimated to be about 2.5 million people in California, and the same estimate by 2019 they estimate that 240 to 510,000 would be enrolled at any point. One of my questions that I've not had answered yet is, why so low? If we think that 1 million people are going to take up the new expansion group, why only 10 to 20% of the eligible but not enrolled? I don't know what the behavior is that they're assuming that would lead to that much lower estimate, especially in the world where there is an individual mandate and this coverage would be largely free. So I'm not making the connection. It's a natural question that I think someone would ask, and so I wanted to sort of just tell you that I agree with that question and I can't answer it. This was not my numbers. It's the UCLA and UC Berkeley folks who run it based on data that they have, and so I will be bothering them to find out. And then finally, we have the exchange cases. Look, I have a laser. And that is estimated. This is not the sort of out there how many people eligible total. This is how many people they think are going to sign up in 2014. So it's a slightly different number from the other two bullets. And that is about 900 to 1.2 million in 2014 people they think are going to come through their door and sign up. And about 250,000 of those unsubsidized folks that I mentioned, the over 400% of poverty. So we're not talking about small numbers here, even if we sort of put a question mark by that 240 to 510,000. It's a couple million, 2.5 million people that we're talking about coming in a short period of time across the state. So who's going to be dealing with them? First, not you, not all of them, don't worry. So I wanted to share a little bit about who some of the players are, and that is the state-level entities. The Department of Healthcare Services, who we work with today, of course, for Medi-Cal, continues to be the single state agency for Medi-Cal. So anything that's Medi-Cal related, the department or the administration, Jerry Brown, the governor, and his departments would be overseeing that, and they would be delegating authority. If the exchange does anything on their behalf in Medi-Cal, it would be only via a delegation of that authority, not giving the authority away permanently or somehow changing the statute. Federal law makes it very clear that they continue to be the people who run Medi-Cal. So then the new group is Covered California. I think they had just been created when I came and spoke in Monterey. This is the name for the health exchange that California created in 2010. It is a 5-member appointed board. They are separate and apart from the Department of Healthcare Services. In fact, they are separate and apart from the administration. It is a standalone entity. It is not subject to the same type of budget scrutiny that departments within the California administrative structure are subject to. That was just the way that the legislation was structured. And so I have their little logos here because you'll be starting to see things with this Covered California logo in particular. It's new. It's colorful, and it doesn't seem to have a lot to do with healthcare, but that's okay. We'll get used to it. So we're going to have a relationship with both of them. Counties will be working with both of these departments to do a lot of this work, and we've been meeting regularly with the Covered California staff to think about how we can help them get people signed up for the exchange. And by we, I mean all of us and counties. So the timeline that we're talking about here is for 2013. Between now and October 1st, it's going great guns to try to put all these policy decisions that I mentioned are still pending together, put training together, and really driving toward this October 1st, 2013 date, which is when the open enrollment period for exchange coverage begins. So essentially at that point, it's going to be pre-enrollment for coverage because the coverage, it doesn't start until January. And it's not clear whether Magi Medi-Cal cases can pre-enroll, whether people who are eligible for that will have to wait until January or not. I think there is some question about whether the federal law allows for that pre-enrollment, and then there's some question as to whether, if states are allowed to opt into that, whether California would want to. So there's a couple of layers of questions that need to be addressed. Everything does start in January, though, both Exchange and Magi Medi-Cal. The coverage is going to start. And then in March, the end of March, the open enrollment period is going to end. And so for the Exchange, this matters because unless you have some kind of a qualifying life event, kind of like what you're probably used to at work, did you have a baby, did you start a new job or lose a job, you would not be able to enroll in the Exchange. They're trying to make it look as much like the private market as possible, and I think the thinking is, sorry, sorry, that's what private market insurance is like. That's what insurance through your employer is like. You have an open enrollment period, and unless something big happens in your life, you're out of luck the rest of the time. Medi-Cal, though, is not changing. They're going to be enrolling at any time, just like today. So your work, won't end. We always do Medi-Cal. Medi-Cal is always open for business. And thinking about how, sorry, woo, I hit the wrong button. John was saying how counterintuitive these buttons are, and now I really agree. So I want to say a couple things about the open enrollment period. This 6-month open enrollment period is only for the first year. In future years, it's going to be October to December, which probably sounds familiar to people because that's when you can change plans, probably if you're in a county that offers multiple health plans, or you have a spouse who has insurance through their employer and you get that window to change your plan. So they're trying to drive it toward that 3 months at the end of the calendar year, just like kind of most other people have. And my understanding is that Medi-Cal is trying for plan selection purposes to drive people toward that open enrollment period as well over time. I don't think that's going to happen right away, but it's something that they're trying to step toward. Again, it wouldn't affect eligibility determinations. That can be done at any time. But for existing people who are on coverage, trying to get them to think about not changing plans during the course of a year, but instead sticking with that plan and making that change during the open enrollment period is a goal of the administration. So I have a few updates on what people have been working on. The Department of Healthcare Services has been meeting with a bunch of work groups, and that included me, our county program staff, eligibility workers that we worked primarily with SCIU to pull together, and representatives from the consortia, the SAS computer systems. Also legislative staff and client advocacy organizations. And the goal was to think through all of these open questions. What does the asset test elimination look like? What does it mean when we say the renewal is going to be different? And think through what some of the pros and cons of certain changes. If there were options for the state, what option would we as a group think that they should pick? And the goal was to create joint legislation for last session. So some of the key issues, I mentioned the asset test. There's questions about share of cost Medi-Cal. These are folks who are above that level of poverty today, and it's a 1-for-1 share of cost, as you know. Well, those are folks who also could go into the exchange now and have some subsidy to get coverage through the exchange. So whether our share of cost program continues to exist in that new world where there's some place for them to go, not just drop off into share of cost, is an open question and one that I think has pros and cons. What happens to court cases? Sneed v. Kaiser is the one I always use. Are we still sneeding kids or are we not sneeding kids? It's not like the court was consulted on the Affordable Care Act and said, oh yeah, that can just go away. I mean, the court cases happened for a reason. The mid-year status report will go away. So that's an important change that will also cut down on paperwork. And then existing programs, and I use 1931B as a good example. Parents and children. Well, parents and children are also going to be subject to this new MAGI-based coverage where you're doing the household like you do with your taxes and you're counting the income like you do with your taxes. But if you cut them off at 138% of the federal poverty level, some folks would have been eligible under 1931B higher than that because of various deductions and the earned income disregards. So how do we think about what we do to make sure that those folks are not disadvantaged? The federal law does say to states, you need to think about these existing groups that you're covering today and not just kick them off or kick them into coverage that's going to cost them money. You need to think about how to protect them and preserve their coverage. And so, again, some open questions and things that we'll be working through is how do you do that? At what federal poverty level do you set for them? Maybe you go up to 185% or 200% of poverty for them. Some of the children's programs, now in January went up to 250%. The way you count income and deductions is different, but what does that look like when you think about converting that into what it would look like under the MAGI? It's a little mind-bending to actually get into those, and don't worry, I don't have any slides that do that math, but making sure that people are not disadvantaged is the real key here, and there's some work to definitely be done there. And unfortunately, we just ran out of time. The legislature did put some bills forth last year that if you're interested, you could take a look at. Last year's numbers, they were identical. It was AB 43 and SB 677. And then SB 28 was just introduced in, I think it was in December, actually, when the new session was sworn in. So you could look up SB 28 for this year's version. It's pretty much the same as last year. That's going to change. I mean, it has to be negotiated. But it's kind of legislative staff's best guess as to what the key issues are going to be, where they think their bosses are going to be, and trying to kind of fire that opening shot across the administration's bow and say, this is what we want. So come and negotiate. So on the legislature, just continuing that thought, someone asked earlier, is there going to be a special session? We heard there was going to be one. There will be a special session. We thought it was going to be called in December, but now it sounds likely to be called by the end of January, probably sometime next week by the governor. And I would expect that to be in session for some number of months. The legislature is very interested in implementation. SB 28 is not the only bill that has been introduced, and there's a lot of bills about providers and rates and lots of stuff that we don't really get into, but that a lot of people in the Capitol arena do and are very interested in. And so you're going to see a lot of legislation in that special session. And the thing is that it's going to be a little tricky because they're also likely to address health reform as part of the budget negotiations. I have a couple slides that I'll get to, but the governor's January 10 budget actually had proposals around health reform. So that means, like, are we doing this in the special session? Are we doing this as part of the budget? Or both? Probably both. And that makes it a little trickier to know what goes in with the budget, what goes in the legislative special session. And at that point, a lot of it is about leveraging each other. The different parties that are interested in having things work out a certain way are going to try to leverage things. And if they're going to give something up, they want something else for it. So politics start to play a role. What the legislature knows and the administration knows from us is time is ticking. If we're going to get training developed, our systems changed, get you and all of your colleagues trained with enough time to actually do this starting October 1st, January 1st, whatever the date is, then we need to get going on this, guys. We can't sit around for 6 months and just only find out this summer what the decisions are. I can say that till I'm blue in the face, and that doesn't necessarily mean they're going to listen, but I'll be saying it. So. There's also an update on the exchange. This is, again, Covered California. The board meets monthly. The meetings are webcast, so definitely check out their website. And many stakeholders attend. I should have put the web address in here, and I'm sorry I didn't. It is bad. It's www.hbex.ca.gov. hbex.ca.gov. They are really focused on tons of things. Eligibility and enrollment rules, kind of our big issue. Assisters and navigators and what that program is going to look like. Think about your current CAA program out there, but kind of on steroids. The payment is coming back, and the training is going to be much more in-depth for them in order to be certified as assisters than what you've seen in the past few years once the whole structure fell apart a little bit at Mr. Mibb due to the budget cuts. Outreach and marketing, a huge issue. How do you brand this? They have the logo that I showed you. Now they have to think about what to do with it. Bus ads, TV ads, radio ads. Are they partnering with sports teams? What are they going to do to tell people what they need to do in order to sign up? And a big question for them that we care about a lot is the exchange is different from Medi-Cal. We want people to apply for health coverage, but they're really focused on that open enrollment period and really trying to drive the traffic of people in that 6 months. What are they going to do for the other 6 months? And how do we how do we make sure that people who need health coverage continue to apply is a big open question that we've asked and it's not yet been answered. They have to select qualified health plans to actually participate in the exchange. They have to get everything automated, the business rules, the plan selection, all of the pieces of these new programs have to get automated. And they also have to put up a small business exchange where small employers can go and buy coverage for their employees, and then their employees can go. So it's actually kind of a separate exchange from the one that just regular people will go to. So obviously there is a lot of work left to do, and again, the clock is ticking. So a couple things, multiple pathways. This is really important to know about because the Affordable Care Act law requires various pathways to exist to apply, in person, by phone, by mail, and online. So the online enrollment is going to use the new CalHERS computer system. That's I'm not even going to try the acronym. It's a rough acronym, sorry. So CalHERS will be our computer system. And if they're able to determine eligibility automatically when someone is applying at home in their bathrobe or sitting next to an assister, they will go ahead and turn coverage on in real time for that person and help them select a plan. What county staff would use is not the CalHERS system. In order so you and your colleagues do not have to toggle back and forth between two different programs, we're actually going to connect an interface to that system, so you all will continue to be able to use your SAWS systems with the rules in CalHERS. So when you run the budget, run EDBC on someone, it will return back. First, it'll go out, look at CalHERS, and run the rules, and only if that fails would they then proceed to the rules that exist in your systems today. So it's an interface that does need to be programmed, and so the three computer systems have been working very closely with the CalHERS staff who are working on building their system, so all of this is going to happen at the same time and be up and running. There are a number of sort of forecasts of who's going to do what. This is from the Exchange Board as well. And they've forecasted this based on the annual applications and enrollments, what % they think people are going to be at. The biggest projection that they think is going to happen is people online. That's the 40% there, the black pie triangle. Both at 20% are the service center, which is their call center, and I'll get a little into that, and also people enrolling themselves online. So online, they actually assume 60% if you add the 40 and the 20. And then I think I should use the laser. So this 20 plus that 40 equals 60, and that's all online. And then people with paper applications, sorry, I keep pointing this laser at you over there at that table. That is the assisters and agents via paper, and that's people who are going to mail paper in. What you might not notice here, or what you might be wondering, where are we? We don't know. And so we've pointed out to the Exchange Board that in-person at county offices is not on this chart. And they've said, yes, we've recognized that, but they've not answered the question. So I think that probably assisters and agents here and assisters and agents here, they assume about half the people are going to seek in-person help from some kind of an assister. I think you could assume that some subset of those folks are actually going to go to the county instead. They're not going to find their way to a community-based organization. They're going to walk through your door. But we are working on some better data projections, and we'll continue. Maybe we could work with the New Paths group to update some of the materials and get that posted to your website as we find out more. So the service center that I mentioned, this is the call center, and it's been a very primary focus of the Exchange. They're going to have 3 call centers, 2 state-run and 1 county-run, and they just announced last week that Contra Costa County is going to receive that contract and run that call center for them. They applied, 2 counties applied, Contra Costa and Stanislaus County, and Contra Costa was chosen. So counties will continue to have responsibility for Medi-Cal, both intake and ongoing. So what they're going to do is when someone calls up, they're going to do a quick sort based on just a few questions that I have on the next slide and try to figure out, does this person look potentially Medi-Cal eligible, or are they more likely Exchange eligible? And if the answer is potential Medi-Cal, this is not an eligibility determination. It's like 6 questions, very high level. The potential Medi-Cal eligibles would be sent to the counties via a warm handoff where a county agent would be able to pick up and help that person apply. If they are look like Exchange eligible, then that person will continue. The person who's helping them right then would go ahead and take their application. So it's really a workload sort, thinking about who takes that application and processes it. If it's potentially Medi-Cal, it's going to go to the county. If it's more likely Exchange, it's going to stay at the Exchange. And our point, though, is to minimize ping-ponging people back and forth, which I know, think about healthy families and Medi-Cal and bouncing people back and forth. So if, they say potential Medi-Cal, they send it to you guys, and you figure out that 2 of the people are Medi-Cal, but 1 of them is Exchange, you do the whole thing. You don't have to send back the Exchange people to do their eligibility at the Exchange. You could enroll all 3 people in that family and just have that turned on. So the idea is to not bounce around. So this is just a sample of the quick sort, and the questions here, they're a little tiny, sorry, on your handout, but it's basically figuring out if the person is actually calling with an eligibility question, and then how many people are in your family, how many children do you have, if any, is anybody pregnant, is anybody elderly, and is anybody disabled, and then what is your income? And from that, figuring out, doing some math kind of behind the scenes to say, oh, this person, because they have kids, they look like they're going to be Medi-Cal, at least the kids are going to be Medi-Cal. Or somebody has a disability, let's get those folks to the county to handle that. We might turn on their Medi-Cal temporarily and then go ahead and do the disability evaluation while they have Medi-Cal coverage, which is going to be allowed now. You don't have to make people wait. So essentially, it's going to be a smart calculator that's going to quick sort all these folks and try to drive to that question of, is there a potential Medi-Cal eligibility? So what's going to happen after that? Say it says yes. It's going to send based on the county of residence, each of the 3 SAWS consortium is going to have a number of participating county customer service centers in a network. It's a subset of counties, most likely. Most Calwin counties have call centers, so we think almost all counties in Calwin will participate. C4 has fewer. They have more counties and a lot of smaller ones, so we're thinking that they would be less. And of course, Los Angeles, unto itself, as I look at Roxana, would be receiving calls for Los Angeles. So the county, the Covered California Service Center would route the calls. The consortia would route them to participating county service centers based on the county of residence, or if that county happens to be really backed up, they could send it to a county that has a shorter queue, so there would be a shorter wait time. But the idea is that the county would just answer that call, take that handoff, and complete the eligibility determination and the plan enrollment. I think about this, like the other day I was calling US Airways and I had to make a change to my flight, and I wanted to ask about using some of my miles for a first class upgrade. So the first lady I talked to did my flight. She changed it for me, and then I said, I'd like to use my miles and see about first class. It was all the way across the country, like overnight, so I wanted to sleep. So it's worth miles for that. And she said, oh, that's not me, but I can get you to the right person, so hang on. So I hung on, and then she brought the next person on and said, Kathy, I have Stacy here to help you. Stacy, Kathy needs to do an upgrade. Great. And then, the first woman dropped off the line, and Stacy helped me. And so that's the idea of the warm handoff, is to ideally pass someone off in a really customer-friendly way, so they're not sitting there with silence or waiting for a long time, but to actually hand them off just like they did with my upgrade, which I did get, by the way. So this is just a little picture of the network. I'm not going to go over this, but it's in your handout. It just is a little flow of how that would work. So the other thing to talk about is the proposals that are in the governor's budget. And the governor broke it into 3 pieces. There's the mandatory expansion, which really are the simplifications that I've been talking about, like the asset test elimination and the annual renewal being a simpler, easier renewal. There's the optional expansion, which is the part we've been talking about that the Supreme Court rendered optional for states. Do you actually expand to the childless, non-disabled, non-elderly adults? And then there's a bridge program that they proposed for those people who are in between 138 and 200% of poverty, which is a pretty mobile and a bit volatile group. I mean, think about folks who are just getting back into the market, into the job market after the recession. Maybe they're working 2 part-time jobs. Things are pretty volatile. They lose a job, they get a job. I mean, they move a lot. And so this population in just above Medi-Cal is expected to be a little fluid, and they wanted to think about how to do some things for them that might help ease those transitions. So in the mandatory expansion, the governor's budget mentions 3 main things. It's actually that changeover of all of our existing cases to this modified adjusted gross income, like I was talking about. It's eliminating the asset test, and then it's this renewal process where we say to them, we think you're still eligible, tell us if you think that we're wrong. And the budget actually includes $700 million, that's total funds. 50% is general fund, state money. 50% is federal money, and it's stated that that would be a placeholder with an intent to work together over the next few months to try to firm that up. The optional expansion, they do propose to do it. Like I said, remember, we don't have any enabling legislation yet, and so they do want to do this. And it's important to know, as I kind of go into two options that they put forth of how to do it, that this optional expansion, as I'm sure you know, would cover a ton of the county's current medically indigent population. So these are the folks that today the county is on the hook for under Section 17,000, under your medically indigent programs. They're going to go into this new Medi-Cal program starting in 2014. So the two options that the governor put forward, one is a state option. Basically, they would say, we're going to build that onto Medi-Cal. We're going to go ahead and do it. It's going to be a standardized statewide benefit package, not including long-term care. That's really a cost issue more than anything else. But the state says to the counties, but we want some of the money that you spend today for those medically indigent, because you're not going to need to spend that money anymore. So, you know, we're not going to say how much we want, but if you get $1.4 billion a year today, we want something like a lot of that. So is what you can kind of bank on. So the county option is the counties would be responsible, and it would be built largely onto the low-income health program that many of you are operating. Most counties have a low-income health program, or LIP. There would be a standardized minimum benefit package, and counties could do more if they wanted, but again, no long-term care. It assumes that the counties would use some portion of that money, like the $1.4 billion that we get today under our realignment programs, that we would no longer have to use for the medically indigent. Instead, we would use them to cover the medically indigent and pay that share and costs. And this would have to be approved by the federal government, because the concept of like less than a statewide program, more like a sub-state delegated program, was not in the Affordable Care Act. It's not in their regulations, and so they would have to okay this. But you see in either part, either the state wants to take some of the county's money, or the state wants the counties to use some of their money. So they're pushing off some of the risk of this expansion over to the counties. The bridge program, I want to say, sorry, go back, just a couple things about this. As proposed, it's either or, it's mutually exclusive. You can't do both. Maybe there's a way that you could mix the two. Counties are currently looking at this, and the County Supervisors Association is taking the lead. We're affiliated with them, so sort of thinking about what the counties want will be a part of that discussion, but they will have the lead for that, given that it crosses over so many different departments in the counties. So, and then finally, there's this bridge program that I mentioned, and the idea here is, like I said, aimed at adults in Medi-Cal whose income goes above 138, but it stays under 200, or parents whose kids are in Medi-Cal up to 200, even if they themselves might not qualify. The intent is to figure out a way to maximize affordability for them, so they don't go from no co-payments and no premium in Medi-Cal to some kind of hundreds of dollars of premiums and co-payments per month in the exchange. They want to encourage the use of local safety net providers to the extent county public hospitals, county clinics, counties are providers of services, and so thinking about how those clinics and hospitals can be utilized, and again, not to see their patients go whoop and drop off. And then finally, getting some continuity by helping getting the Medi-Cal managed care plans to participate in this. So this would actually be run by the Health Exchange, by Covered California. They would be the ones negotiating with the plans. They'd use qualified Medi-Cal managed care plans. And there is a question about whether they should try to include kind of look-alike people who are not Medi-Cal eligible. So there's people who might be up to 200% of poverty who were never on Medi-Cal. So their income didn't change, they just were never on Medi-Cal. Should you cover them too? Why would you cover someone who looks similarly situated to them and not cover them? So that would actually require federal approval, and there was a big discussion at the Covered California board meeting last week where the private plans who are part of the exchange structure who do not do Medi-Cal complained about this idea because it's cutting into how many people they might have enrolled in their plan. So it's a lot of a fiscal issue. And Covered California board actually split on this option and didn't vote either way. So what they did was they directed their staff to work with the administration and the federal government to kind of look into this issue and see what this bridge program ought to look like. Important to know, the legislature would have to weigh in on this as well. So we're not quite sure what's going to happen. So what we're working on at CWDA is thinking a lot about county readiness and kind of how to help counties think about how to review their current practices and procedures and get ready for the implementation. And so this includes two main projects that we're working on right now: a best practice and culture change project funded by the California Endowment, and then a project to develop a readiness checklist that counties could use to internally look at their operations and think about what might need to be changed. The ideas behind the Best Practice and Culture Change project was really germinated by a researcher who did a lot of work with individuals who he had apply for Medi-Cal and healthy families through various methods, using your system, your online system. Some went into your offices, some called the Healthy Families 1-800 number, some used the Oney app. It was just all different methods, everything he could think of. And then he surveyed them about their experiences. And largely, you all did pretty good, actually, which was great, and I was not surprised. It was a nice finding to see that backed up. And one of the things that people did say was things like, well, the office that I went to could have been look a little nicer, things like that. And so it was right in the middle of the recession, and I know people had, lobby management practices were being changed and experimented with a lot because you had so many people coming in to apply. And so I wrote down in my little notebook, buy a potted plant, because I was thinking, how do you make your office look nicer? And it really germinated this idea of what is customer service in the public sector, and can we draw on best practices that counties learn, either during the recession or before that or after that, other public sector programs, other private sector programs. I think a lot about H&R Block and how you see them in storefronts, and people from all different economic groups go to H&R Block and sit down with their person and figure out what their taxes are. So I think there's some best practices that we can learn from that, and we were able to get funding from the California Endowment to do it. And there's been lobby surveys, eligibility worker focus groups, a symposium last week that some of you came to, and we're looking in March for a report, and the report is not going to say, pick one from column A and one from column B and your customer service is fixed. No, it's going to think about strategies that can be used that are promising, and also encourage counties in partnership with frontline staff up to the director level. Everybody should get together and think about, as we go into 2014, how do we put our best foot forward, and how do we give that best customer service and build on the work that you all have already done locally to ensure you're providing good service? How do you take that to even the next level? So we're pretty excited about that wrapping up, and we're also thinking about some next steps on both projects that we think we're seeking some additional funding to do some out on the ground work to try to help some counties kind of step through that and then share those results with others. Developing training materials and disseminating that. We've been also talking with some of the unions about working together on that, and just providing any assistance that we can to try to, do that training, get you all ready so we really hit the ground running when the time comes. How am I on time, by the way? I don't have a watch. My watch got smooshed. All right, good. Thank you. So just thinking through the role of county eligibility workers in healthcare reform, like I said, here's why you're all here, right? There is going to be a significant role for counties in the healthcare reform implementation. You're the primary in-person pathway. I mean, there's going to be assisters and navigators located in community-based organizations. They will be helping people apply. People are going to walk through the county door. They do today. There's assisters out there, there's people to sit down and help them, and yet tons of people walk through your door. So we know that tons of people are going to walk through the door. So the primary in-person pathway. Counties will process applications that are going to be submitted via the county online portals, who get call you guys, or the mail-in applications that are sent directly. So just like today, all those pathways still exist, and that'll continue to be a county job. Like I talked about, the warm handoffs from the exchange call center, that's a county job. We are also going to handle the online and mail-in applications that are submitted to the exchange but need more work, and a quick review looks like they're likely Medi-Cal. So we're still working out exactly what that sort would look like, how they'll sort that workload, but there is agreement that if it's obviously a Medi-Cal case, that work should come to the county. That should not be done at the exchange level. And then finally, like I mentioned earlier, everything related to anything other than MAGI, all non-MAGI intake continues to be counties. Counties also do all Medi-Cal case management, both the Magi cases and the non-Magi cases. And then a new opportunity is to help individuals actually take that next step and enroll in plans. That might look different from one county to the next, so be thinking about that. Do you want to think about that as an opportunity for really interested eligibility workers to do some extra training and have that as the role? Or does everybody get trained on that, maybe in a small county? It might look different from one county to the next about how that's actually implemented. So some of the new opportunities, I think the simplification of Medi-Cal rules, hopefully chasing fewer people for less paper. Just anything that we can do to cut that down. We've talked about that for years together. Will leave you more time to do the actual work that you were hired to do. The intake for the exchange eligible cases is a new offshoot as well. Similar calculation of their income and their federal poverty level, but it is a different program. And so thinking about how to talk to someone who's maybe their children are in Medi-Cal and the two parents are in the exchange and stepping them through that is a little bit of a different change. The plan enrollment, like I mentioned, horizontal integration, which I'm going to touch on in 1 second in another slide, and then thinking about, like I said, how to build on those customer service improvements that we've all been striving to make and building on that culture of coverage instead of having to say no to a lot of people. For most people, it's going to be, yeah, we're going to get you eligible for something. Now, what is that going to be? Let's figure that out. And so it does flip a little bit that presumption of, I need to keep you out if you're not eligible, to, you're going to be eligible for something. Let's figure out what it is. And so I think that's an exciting change, and also speaks to maybe some changes in how the interactions go, hopefully for the positive. So this horizontal integration that I mentioned on the previous slide, I want to really touch on it because it's something that the counties do better than anyone, and we're kind of the only ones who do it, so I think it's really important to think about the implications. The federal law requires this, but it's really vague. And what they say is that if someone's applying for a health coverage program, you also need to connect them with human services programs for which they might be eligible. Which ones doesn't say. How to do that doesn't say. What time frame? It's not in there. It's very vague. And I mean, states are really focusing, I think, understandably, on health. They're not thinking about the human services piece. But you guys are already horizontally integrated. When someone walks in your door, calls you, or submits the online application, we're trying to get them to say, yes, consider this for that other program. And so it's a real, I think, competitive advantage, one that we've thought a lot about, and one that we've worked with a lot of organizations here in California who are very committed. A lot, of course, around CalFresh with our participation rate that is lower than many other states, even though we've added tons of new people as a part of the recession. There's still tons of people who are eligible out there but not enrolled. And so thinking about how we can work with those groups and internally to make sure that, hey, if it's vague at the federal level, if most states aren't focusing on it, if the exchange isn't really focusing on it, that's okay because we can. We can still get folks enrolled in the programs that we operate. And again, CalFresh, CalWorks are the two major ones that you all are potentially going to be doing at the same time. So not losing sight of that horizontal integration, which is a real opportunity for the counties and for county eligibility workers that we have today that will continue, is one that I wanted to in particular mention. So some next steps, some thoughts on that. We have to finalize all these new rules. I've been saying, I think, throughout this, and that's coming, or we haven't figured that out yet. It's frustrating for me. I'm sure it is frustrating for you as well. Counties and staff, I mean, down to the, I hope, eligibility worker front line would play a role in this. Because what I've come to realize, I mean, I've been doing this for 13 years, and if we're not talking to folks who are actually doing this, then it gets all messed up. And so, and I've been the culprit at sometimes, and I've been the recipient at others. So I try not to be the culprit. I try to make it not happen, try to work with you all. And I think just even in the last week, we were hearing from some staff at the state level that they're working on a letter with some policies. And I said, hi, were you going to actually talk to us? Because I don't know what you're writing or what policies you're focusing on, but you all don't run these programs. And they kind of had to take a step back and go, oh, yeah, you're right. We kind of screwed that up. So we kind of continue to have to knock on the door sometimes, but definitely see a role for all of us in this room to really play. Obviously, the training is going to be a big deal. There's rules changes. The technology is going to change. The computer systems have to interface. I'm sure there will be changes to what that looks like and what button you push when that we'll need to make sure everyone is trained on and implement that new technology. And then assessing the staffing needs. I mean, those numbers that I showed are not small, and thinking about how that translates into new staff, offset by simpler work, we'd hope, right? So what does that look like? It's not a simple calculation, but it's one that we need to figure out and give counties enough time to actually bring staff on, hire, train, have desks for them, that sort of thing. So what can eligibility workers do? I mean, just some thoughts, and I think the folks who are next on the panel are really going to get into this in greater detail. I mean, I would say look for opportunities to volunteer locally. I think folks have been kind of champing at the bit to get that started, and until we have more information about what all the rules are, it's been hard to get stuff started locally, so be patient too, I would say. But definitely, look for opportunities to help with the assessment of the training needs and staffing, actually developing and delivering the training. I mean, you guys are the leaders here. You're the ones who come to this organization, you're the participants in this, and so I think of you as the leaders who can really take this back. Familiarize yourself with the law. I mean, I think, we still have to translate a lot of it to California, but I wanted to put a couple of places to go here. The Kaiser Family Foundation has some really great materials. They're briefs. They explain what MAGI is. I mean, they're like 4 pages about the MAGI rules and what the households are going to look like. That's great stuff. So if you have, time, go for it. And then healthcare.gov is the official federal site, and that's one to keep an eye on as well. Definitely participating in all of the training and activities. And like I said, just being a leader, participating in this organization, participating in the groups that the unions might put together locally or within your locals would be really important. And questions we are not taking now. So I am done. Thank you. We'll leave that there for the next one.
Thank you, Kathy. Our next panelist is from the Alameda County Social Service Agency. This is Randy Morris, who's the Assistant Agency Director for Adult Aging and Medi-Cal Services Department.
Trying to find the PowerPoint.
Oh, there we go.
He's loading it up.
All right. Randy started his career in Alameda County as an MSW child welfare intern in 1994. He was then hired on as a child welfare employee in 1995 and worked in child welfare until 2011 when he was promoted to his current position in fall of that year. Randy.
Okay. I thought it would be important, especially for those from Alameda County, but for those of you from any county, just to kind of take those big, huge state numbers and kind of ground it. And so what's that really mean for a county? And we're a pretty medium, large-sized county. And so I'm going to walk through Alameda County Medi-Cal data and just let you know how many are enrolled in Medi-Cal, how many were preparing to move into Medi-Cal when the Affordable Care Act is implemented. The second is in answer to the question I was asked to speak to, which is what are you doing in your county to prepare for healthcare reform? One of the things that strikes me is that the word healthcare reform means different things to different people. If you talk to somebody in the healthcare service agency or a community-based clinic or a hospital, that means something very different than it does to us in eligibility as it does people in our community who aren't in the government services. So I wanted to take a minute to share with you some of our work to try to define it, because I think until it's defined, sometimes you're talking about this and people are thinking that. And then I'll end with just a bit about what we're trying to do to prepare a foundation, because hopefully what you heard from Kathy is there's a tremendous amount of unknown and still being determined at the federal and state level. So it makes it difficult to begin very specific plans, because we're sort of preparing and bracing ourselves and building a foundation to get ready to move very fast if this time frame remains. So the data. We are a piece of a large pie of public health coverage, as you all know. And Kathy mentioned things like indigent care. Counties are responsible to provide health coverage at the local elected level at whatever degree, and it's different in all counties. There's healthy families in that transition. There's this LIP program. And there's Medi-Cal, and Medi-Cal, for those of us in social services, is tied to cash grants through foster care and CalWORKs, and then there's sort of Medi-Cal that's not. And so this is just an idea of our numbers, give you an idea of our size. And so if you look at the left, the larger pie chart, under about 325,000 Alameda County residents have some form some form of public health coverage. About half of that is a Medi-Cal only non-cash case. So by far the largest percentage of public health coverage, and this is probably somewhat reflective of most counties. Then what we also administer, CalWorks, about 40,000 on top of that. And then I know there's a few foster care people from my county and probably others here. I used to manage the foster care eligibility program, and that is a very complicated program. And then I realized when I moved to this position actually how small but important piece of the big pie that is, and that's that red sliver. And then you move over to two other very large programs. And the green, Healthy Families in Alameda County has hovered between 20 to 21,000. We are in the middle of that transition right now. Actually, this is my way to think of this in a very positive, solution-focused way with all the challenges and work involved. It's a good precursor to what's to come. A lot of the work we've had to do to kind of transition a population into Medi-Cal, I think is a sign of what's to come. And then the yellow slice of the pie, Kathy mentioned the LIP program. A lot of counties, well, all counties administer some version of a indigent care program. It's on the county dollar. There's no federal or state dollar. And the federal government made it an opportunity for counties to get some federal money, 50 cents on the dollar. And Alameda County Healthcare Services Agency, our partner system, administers the low-income health program. And in Alameda County, they call that Health PAC. And that is now almost 90,000 individuals. And we broke that pie chart out to give us an idea of what we're preparing for, because Health PAC includes both the indigent care program in Alameda County, those who are not eligible for any form of federal or state-funded health coverage, and then two types of coverage, one called MCE and one HCCI. And MCE is the 133% of poverty level and lower, and that's the group that should be transitioned into Medi-Cal come 2014 with the pre-enrollment work before. And then the green slice, 40,000, no, the yellow slice, the very small slice, that's the groups that's 133 to 200 that should transition to the exchange. So without pointing fingers, I know the clerical manager from Alameda County is in the audience, and so hopefully we will not have to do 42,278 file clearances in the month of October, and that's a lot of the sort of stuff we're trying to prepare for and figure out how to automate. So that's a bit of the numbers. I think this next one is important for a matter of public policy, which is the Affordable Care Act does not create universal health coverage. It significantly bridges the gap between who is eligible for federally and state-funded coverage and those who are not. But this gives you an idea of Alameda County numbers, and this was done by a local organization, the Alameda County Consortium, that got a grant to look at some 2010 census data, and so they're the source. And it was estimated at the time this report came out, halfway through 2010, that in Alameda County there was somewhere, hard to count, 200 to 250,000 individuals who are uninsured. If you break that up, it basically breaks down into three groups. Half of them are people who will be eligible for some form of exchange-based coverage. About a quarter of them are eligible for Medi-Cal, and that's the group Kathy mentioned. They're right now not categorically linked, but they will be. And then there's still about 60,000 who are not eligible, and that still remains a public policy issue. So that gives you some sense of the Alameda County numbers that we're looking at. Okay, so this is that topic of defining healthcare. I hope this is helpful to you. It was helpful for me because we get a lot of questions from a lot of different sources, from you as our staff, from our partners, from our elected officials and their aides, and all types of people saying, so what are you doing for healthcare reform? That's a big, big, big bucket. And so I wanted to share with you kind of how we're defining it, just to then bridge to sort of what that means. So on the left side, I want to start by saying the way we're organized in Alameda County is we have all the Medi-Cal non-cash cases delinked and removed from our cash cases in a department which I manage with all of our adult and aging programs, and I'll say a little bit more about that. On the adult and aging side of the house, the largest program is called the In-Home Support Services Program, and you may have heard, and some of you who do IHSS Medi-Cal, that's a Medi-Cal funded program, there is a very large healthcare reform stimulated activity called the Medi-Medi, or Dual Eligibles, or Coordinated Care Initiative, and that was created by the Affordable Care Act saying, and this is my language, this is not very correct in terms of the way the feds would describe it. But essentially, you have Medicare at the federal government, and you have Medicaid, or Medi-Cal in California, and they are not integrated. And if you think about it from the perspective of a client, they have to navigate this very complicated world of 2 funding sources, and they have 12 business cards, and I get this covered by Medicare and this by Medi-Cal. The concept is you should just have a card, and somebody should coordinate your care if you have dual coverage. And Alameda County and LA for sure, and some others are part of the 8-county pilot in California. So on the IHSS side of the house, we are implementing a very large piece of change called the Coordinated Care Initiative, or dual eligibles, which is part of the healthcare reform planning. That's not Medi-Cal specifically. The second one up there is the Medi-Cal expansion, and Kathy covered that, which is definitely created by the Affordable Care Act. So those are 2 Affordable Care Act created changes that will impact social service systems. But I want to add this third group. Healthy families is one everyone would know, and that's a form of coverage that, as I understand it, was before my time, used to be Medi-Cal, the state of California, that said, oh, for this group it can be a state program. The state vendor Maximus has it. Now it's being moved back to us. And so there is a whole lot of activity going on, and thank you to Kathy, thank you to Kathy, thank you to Kathy, who helps all of us kind of keep grounded, and this transition is very complicated, and we're in the middle of that. That is not directly related in any way to the Affordable Care Act. That's a state of California action. But in terms of what we do as eligibility, it's sort of similar. We have to figure out how to move a big group of people into our system and how to get them on coverage and keep them covered and talk to the state. But we keep it separate because it's a kind of California initiative. And then the 3A is something, at least as I understand it, that is unique to Alameda County, and we're sharing just a little bit about. And this is called the Connecting Kids to Coverage Initiative. The precursor to what I'm going to say is, Kathy mentioned this, there's a lot of estimates that just because somebody is eligible doesn't mean they're enrolled. And that's one of our challenges, and we got a lot of attention in counties. What are you doing to bridge that gap? What can these APA sisters do? How can we better bridge that gap? The Connecting Kids to Coverage Initiative is sort of a name for the Federal Health and Human Services Secretary, Kathleen Sebelius, who a few years ago said, hey, country, we have a problem. There are 5 million children who are eligible for some form of public health coverage but not enrolled. I issue a challenge. Figure out how to get them enrolled. It ties directly to their well-being. And so Alameda County's Board of Supervisors said, we'll do it. And they turned around, and this turned into an initiative that's got a lot of activity. And it sort of connects back up to what we're doing in our merging our strategic planning efforts, because what we found is the things you all know and live every day, which is it is complicated to get to hard-to-reach families. Once they get on, it's hard to renew. The renewal process is complicated, and these issues hopefully will inform us locally about what we can do when we move to the newly eligible indigent adult population. So that structure on the left is kind of how we're starting to define healthcare reform, which is these children's initiative and Medi-Cal expansion we're putting together, and then we have a whole other set of activity we're doing with the dual eligibles initiative. Okay, to the right. I believe most of us chose this line of work not because of the stock options and the great things we get as public servants, but what you care to make a difference and hopefully sleep well at night thinking we're at least trying to do something better in the world. But I'm always impressed by what a piece of a very large puzzle we are as a social service system. And I wanted to walk through that little inverse funnel on the right. And this is a graphic that is used by our local Alameda County Healthcare Services Director. And there's 2 different ways of looking at this. There's a way of looking at glass half full and glass half empty. So I'll start with the half empty so we end on the positive. This is what my colleague refers to as the Achilles heel of healthcare reform. And that is, to start at the top, just because you're eligible, then you go down, doesn't mean you're enrolled. That's us, eligibility and enrollment. Now let's move to the world of the larger system of healthcare delivery. Just because you're enrolled doesn't mean you have access. There is a huge set of issues going on about reimbursement, the Medicare rates, the Medi-Cal rates, not enough doctors, not enough nurses, not enough clinics. And then just because you have access and you actually get service doesn't mean you achieve the outcome of improved well-being, improved health outcomes. I mean, sometimes it's, you know, safe schools, safe neighborhoods, clean air, clean water, and maybe healthcare isn't the issue. But this is all about trying to make more people eligible. We have a huge role in helping getting them enrolled, and then our partners in the service delivery system have an important task to try to get services to them to achieve the outcome. So the Achilles heel is there are failures every step of that way, and that is a big set of public policy discussions and papers and briefs and all over about every one of those steps in that sort of funnel down. The glass half full is what an opportunity. You know, there is a huge number of newly eligible adults who have arguably some poor health outcomes, and there's lots of literature out there and lots of reports that have said you are more likely to get preventative care if you have coverage. You're less likely to go to the emergency room too late, and we have a huge role in that. And so, yes, there are problems. Yes, the system falls short, but wow, what an opportunity do we have. So I think just grounding us back in what this is about, which is to help our customers have better outcomes. Okay, maybe as exhausting as Kathy's presentation. All right. I'm going to admit that I first put this together for myself because I was kind of confused about this and wanted just a visual to look at real quickly. And this is just me. This is just my thinking, and hopefully it's helpful to you to think about. I think Kathy mentioned and actually didn't quite realize how vague the federal language was about, oh yeah, when they enter public health coverage, you should try to get them on these other things that social services has, no definition, no specifics. It's my experience in my little teeny corner of the world in Alameda County that there is so much discussion and energy and complications and technology issues and funding issues on that blue line, which is the spectrum of health coverage. It is a very complicated world right now, and hopefully it'll be less complicated, but best I can tell, it is still going to be complicated. There are still these 3 different buckets. There's still an indigent care program. There's still 60,000 people in Alameda County who are not eligible for Medi-Cal. There's the Medi-Cal program, which now has healthy families, and the LIP will move into it. And now there's this new world of 133 to 400 through the exchange. And Kathy mentioned that the goal is to make it seamless, and the goal is to have the systems talk to each other. And then I can just look at you and say, how well does SAWS and meds interact? And it's certainly never hiccups, right? So I think we are going to strive to have this be seamless, but that continuum is so much to that I think, and these are the things I call Kathy about and email her sometimes, I think there's a risk of losing our continuum, which is we connect on Medi-Cal, but families are eligible for food stamps. They are eligible for other programs. And so we put this together to just say where we connect is Medi-Cal, but there is a lot of local discussion in Alameda County about how to change the way in which people are enrolled into care, and we have a lot of discussion right now about the local healthcare agency's system called 1E app, which some counties use, and why not shift to Benefits CalWin? That's easier for us. Oh wait, let's wait for the mothership CalHERS to open up because that'll make everything perfect. But what about our responsibility to not lose sight that many of these families are eligible for CalFresh, of course. So anyhow, this was just a visual to say there's this axis, and not by anyone's design for sure. It creates a little bit of a competition. And because the Affordable Care Act, all the focus is on the blue, and I think we have a role as social service systems to not forget, well, first of all, we have to get in the room sometimes. That's what Kathy does for us, and not forget that holistically families will benefit from other programs we have. Hopefully you weren't too exhausted. Okay. All right, so this sort of ends with kind of what are we trying to do locally. So the top 6 are just kind of a short list. I'm going to remind myself I should have put data systems up there, so I'll hopefully remember to come back to that. But first of all, we went through, and anyone in Alameda County, just look at them twitch when I say this. We went through an agency reorg number 72 in the last 12 years or whatever it was. But it was a pretty massive reorganization, and that was the employment program that used to be standalone got integrated with the CalWorks program, and the Medi-Cal program got integrated with the adult and aging programs, and that's the department I manage. And there's the twitch. And you know, any big, huge system, I feel like I've just finally been around long enough that every time I've been in an organizational structure and complain, it needs to be this, then you go to the new one, and that doesn't work. Anyhow, it's complicated, it's big, there's pros and cons. But there were sort of 2 drivers of that, and it was part of preparing for healthcare reform. One is, if you go back to that visual of the pie, that half of public health coverage is Medi-Cal. Now Healthy Families is moving in, the LIP is moving in. It's going to be way more than half. By far, the biggest program that's run by you all, many of you all, is Medi-Cal, not tied to a cash grant. And there was a thought that, and I'll watch you all when I say this, see if this is true, but we heard a lot from staff that when you have an overwhelming caseload and you have clients with cash and you have clients with not cash, and there's like, I need my renewal, I need to pay the rent, sometimes we focus on the CalWorks renewal and anyhow, so there was a thought of let's really focus on Medi-Cal. I mean, this is a huge program, let's focus on it. And the second is, which is more in an administrative world, in my world, is it really positions my department and my appointment to this position is now all the healthcare reform related activity is consolidated in one department. So when I sit in meetings on behalf of my director with people in healthcare and the hospitals and the clinics, they're talking about the coordinated care initiative, the Medi-Medi, the changes that, and it all sort of concentrates in one operating department at our agency. So that was one of the things we did structurally to prepare. Second and two and three is we have hired 2 new full-time people to give us some more infrastructure. I don't know what I would do without our analysts who sit on all these calls with Kathy, because I've sat on some of them, and then I have to call them after and say, what did Kathy just say, and translate all that. But you know, you all have these analysts who do all the newsletters and handbooks and translate down at the detail that helps a clerk know what to do in the system and get, so we have, and our analysts were getting very, very behind in the ABCs of kind of keeping the Medi-Cal program up because they were getting put on all these committees and, you know, so we brought a third, we have 2, and we brought a third in just to get to the ABCs to kind of give us a little infrastructure to kind of keep up. And then the third item there is we did hire, under our policy office, a full-time healthcare reform fellow to sort of help us look at the things happening at the federal and state level. And that goes up to and including putting this PowerPoint together for me. If we didn't have the person hired, I would just be talking. But it really sort of helps us get a little bit ahead of the curve. We get a lot of questions from our board office, a lot of questions from community partners, and then me and others in positions like me can talk to this person. They put things together that we don't have the capacity to do otherwise to kind of keep the communication going. The fourth one is, I'll come to the fourth one at the end because that's actually what's at the bottom. We've created 2 standing monthly committees, and I'll end with that. The fifth one is we are really in the process conceptually of looking at the way we're organized. You know, we have labor agreements. We have a very active union, and we work a lot with them on any change. And we are looking at whether or not the way we are structured is going to position us well or not well. And we better get ahead of that now if we're not organized well. The call center was mentioned. We do have a call center. And I think this is being posted on the web, so I will not say how long it takes for a customer to get a live answer at our call center. But we also have the wrong classification answering the phone for what the Affordable Care Act requires of the handoff. And there's a whole host of things we have to do to think about our call center so that we do the upgrade to first class that Kathy experienced with our customers. And we also have an outreach program. We have, I think we're in 58 locations in the community where we pick up Medi-Cal and CalFresh applications, and we're kind of looking at whether or not we're in the right places and whether or not we did kind of tweak that. I said I'd say data, I remembered. Data, I don't know about other counties, but I think with the workforce participation rate and all the changes to CalWorks, a lot of our data systems are organized with all programs, but we really didn't have a standalone Medi-Cal sort of data system to just really look at our Medi-Cal, where people were applying, where they're applying from, which board district they were in, ethnicity, language. And so we've created some data systems to look at Medi-Cal intake and Medi-Cal renewals and really start reviewing that to see if it tells us anything. And I think that was a step. It really sort of was part of that commitment of the reorg to say we really have to look specifically at our Medi-Cal program. Okay, I'll do communication plan to end. So at the bottom of that, that's the committees. Our agency, we have a relatively new director of a year and a half ago or so, and part of her commitment was she had 3 major initiatives, and one of the initiatives that she wanted for the agency looking forward was to prepare the agency for healthcare reform. So we have a standing monthly internal meeting, and that's what's on the left there. We talk about the Connecting Kids to Coverage initiative, the Healthy Families transition, what we're preparing for LIP, data exchange, and we have all of our key partners there. We have our training department there, we have our finance department there, HR. We're kind of just starting to talk through so that we make sure we're always thinking of all the moving parts in our agency, and it really reminds me how hard it is to think about the entire system. You know, you start going down a road and the training department says, wait a minute, I need another trainer if you're gonna, you know, so there's a lot of things we're trying to think through. And then we have this joint partner committee which meets monthly, and that is where we meet with our partners in Healthcare Services Agency. We in Alameda County have a standing monthly healthcare reform subcommittee of the Board of Supervisors, which is 2 of our Board of Supervisors, and their aides come to this meeting. We have the local federally qualified health clinics. We've added behavioral health care. And we sit monthly and try to figure out the interaction between all of us to make sure our planning is synchronized. So my final, number 6, I want to fully admit to you, I put this on there as something we need to do that we haven't done, and that is really the communication plan with you. We, at least in my position, get pulled a lot towards responding to the external and to the board and to the community and to our partners. And there is more work to do, and I believe we've fallen a little short about sharing with you all, our staff. But the complication is what you heard from Kathy, which is even if we set up a monthly meeting or a monthly newsletter, it would be there's these big things coming. And maybe describing, but a lot of times you just need to hear, well, what's this mean for me? I saw all of your heads turn down and start writing, and you got all excited when Kathy said the mid-year status review goes away. Something practical. Okay, I get it. You know, the rest of it, you're a little glossy-eyed. But I think there's, you know, very few things right now where we can say this is what this exactly means for you. It's very big picture, and yeah, some of you are interested in that, and some of you are like, what's this mean? So we are in that internal committee going to, at that monthly meeting in the next month or two, really start thinking about how to create a communication plan so that we have sort of regular communications. We'll be borrowing heavily from the stuff CWDA and other associations put out, hyperlinks and whatnot, but we just want to make sure you know we're doing things, even if you don't see it, to try to get our foundation ready. So I too had questions in my last slide, but that's after the other presenters. Thank you.
Thank you, Randy. Next up, we have June Hutchison, Deputy Director, Customer Service Center, Traditional Assistance Department for San Bernardino County. June is the Deputy Director for San Bernardino County. She most recently in June was the C4 Regional Project Manager for San Bernardino County. That, of course, the automated system in 39 counties in California. While in that position, she was instrumental in the grant writing and implementation of the C4 Yourself online application. June has been with the county for over 23 years and has been a training instructor, lead worker, and eligibility worker. She has also been a program specialist where her duties included developing coordinating material for programs like Medi-Cal, CalFresh, CalWorks, and childcare. June?
Thank you. Hello. Welcome to San Bernardino County. I know you already heard that, but I have to say it again. We are so glad you're here. And my presentation today, as you can see from my slide, my one slide, is going to be very simple. And sorry, I move a lot. I just freaked you out, didn't I? Anyway, so we are immersed in our heads in healthcare reform in San Bernardino County. You know, there are, as Kathy mentioned, lots and lots of things that we don't know yet. Nobody knows. You know, it's one of those things, but nobody knows that. But we're still waiting for the answer because we need to know. There are questions that we still need to know. One of the things that I kind of think is the coolest thing about this, and I know this probably sounds a little silly, but you know, when I was an eligibility worker and we would sit around and say, why is the county doing this to us? Why are they making us do this now? And I think this healthcare reform is the best example we've had in years of how a bill becomes a law and what it does to you. Because it's going to change all of our lives. It's going to change how we do things. And It was something that was created at the federal level. And what we don't always recognize is that happens a lot. Sometimes they're just little tiny things that we get it, comes to the states, and ACWDL comes to the county. You might get it in program material from your county, but it's really come from much higher up. And that's what this one is too. But it's just a really good example of how it's gonna change things for us. So going with your theme of rev up the engines, I consider us sitting on the starting line. Our motors are already running, and we just don't know when to say go yet, but we're already ready. And what we are doing, and what I think you are doing right now, is in the stages of gathering information. What's happening, what's gonna happen, when is it gonna happen, how is it gonna happen, and just gathering that information. So you've learned a lot today, I'm sure, from what Kathy has said, and she gave you some good pointers about going to the Covered California website, the Kaiser Foundation website. All of those websites have good information. You know, looking at Covered California, looking at what their goals are. Their goals of universal coverage for everyone. High quality customer service is one of their goals. Coordinated services, so all that horizontal integration that Kathy talked about. And what did I miss? No wrong door. So it doesn't matter that they come in our door and say, hey, I want to apply for that healthcare thing I've heard about. We're going to help them. And it's not about, you know, what they might be or are they eligible. It's what are they going to be eligible for? And we're going to help them regardless. So that's something that as a county we have to think about. New people coming in, customers that we have not ever dealt with before, brand new to us, and it's more of a difference between, you all know the difference between, you know, the elderly grandma Medi-Cal customer and our, you know, person that's coming in for CalWorks, CalFresh. There's a big difference in the kind of people they are. Well, we're gonna see a whole new crop of people we've never even met before. And we need to be prepared to deal with them and work with them and help them and provide them coverage. And that's going to be a big change for us. So in strategizing, which is my next step on my little racetrack here, is strategizing. Let's figure out what we need to do about this. I might need to think about my lobby. How am I going to deal with all these people that are going to walk in? Because we kind of are that in-person option. So what am I going to do when they walk in the door? How am I going to change my lobby, reroute my lobby, do something different in the lobby? Because there's going to be a lot more people in there possibly. So in San Bernardino County, we're thinking about ways that we can change the lobby. We already interview at our desks, so we don't interview in the lobby. We take the customer back to the actual eligibility worker's desk, not just a desk, but their actual desk. So that takes people out of the lobby. But to give customers more options for self-service in the lobby, let them come in, take care of what they need to take care of, and go. So they're in and out, and they're not hanging out there for hours, waiting for something. Doing things like marketing the things that we already have available to us, marketing those interactive voice response systems. Get people now, our customers that we have now, start getting them more into using those things so they're not coming in or calling us, and they can self-serve those other ways. Online systems, IVR systems, you know, using social media to contact and give information to our customers. Because you know in the most recent months, we've gotten all kinds of flyers sent out to our current customers, right? Healthy families things, what is it, 24-month clock things, all kinds of flyers, ARCO cases. People are getting all kinds of flyers. If you can put that flyer out on a website somewhere or on Facebook where they can go get their basic questions answered, because everybody doesn't understand those, right? We don't understand the flyers sometimes. So putting that stuff out online, and I know it sounds maybe silly to say, like us on Facebook, but we do. And we have a Facebook, and we're trying to put job leads out on there. And I know people might not like us because they don't want all their friends to know they liked us, but they still might visit. And you can get data on that on a Facebook page to see who visited. And that way you can kind of divert some of those questions, the calls to your contact centers, the people coming into the lobby, and try to send them other places so that we can kind of free up what we're doing now. Use the tools we already have available to us to send people those directions so that we're not going to be filled up in the lobby with these new customers. Training, thinking about all of this stuff you just learned. What's the difference between Obamacare, Affordable Care Act, healthcare reform, Covered California, the exchange? It's pretty much all the same thing. But thinking about things in terms of, I need to get that message out to my staff now. They need to know what all those things mean. We need to start using that right technology or terminology. So doing things we're doing in our county, starting very soon, is something that we call Term of the Week. Sending out a little flyer that says, hey, guess what? All these terms, they kind of mean the same thing. You know, it's kind of like the SNAP program and CalFresh, right? So Affordable Care Act, Covered California. Okay, so thinking about things like that. So doing Term of the Week, getting people, she says no, getting people involved in the terminology so everything isn't brand new coming in October or January. So Term of the Week, so strategizing those things. Eligibility changes, who you have working in your customer service centers. Is it that person that can take that warm handoff? Can they do an eligibility determination when they get that call transferred to them? So thinking about that stuff. Also thinking about the staffing. You know, it's kind of a scary thing to me, but during this whole open enrollment period, we have to be able to take those warm handoffs, and it's not in our normal hours that we work now. They're expanded hours till 8 o'clock at night. So thinking about, how am I going to do that? Who's going to take those calls? How am I going to do that in my current staffing? How am I going to hire people? Could people work at home? Right? Because probably the person that Kathy got transferred from, what is it, US Air? That was probably somebody sitting at home. Not everybody that works in a call center that takes a phone call is sitting in an office building somewhere. That could be us. And we are exploring that. Is that an option? So that's all the strategizing that we're kind of thinking about in our county. We have a steering committee. Our steering committee was made up originally for the low-income health plan. Now we're moving it to healthcare reform. And it includes all the partners in the county. Everybody that probably needs to be involved. Public health, behavioral health, training, our county hospital, our managed health plans, and working on figuring out, okay, how are we gonna get from here to there? So that's kind of strategizing. Once you figure out what your plans need to be, how do I need to change? What do I think I might need to do? Then finalize the plan and start working on it. So what changes are we gonna do? Who needs to be involved in these changes? You all wanna be involved in your county? I would. I want to. I want to know what's coming. So really getting the buy-in, getting people involved that are really going to do the work and to help us understand what needs to change. What could we do better now to reduce the impact later? I know that I think Randy and Kathy mentioned CalFresh. We have an awful lot of CalFresh customers that don't receive Medi-Cal. Well, that's part of those uninsured people possibly. So let's hook them up now. Let's market to them now, get them into a Medi-Cal program if that's what they're eligible to, and that's one tick off the list, right? I signed them up. I won't have to talk to them in October or January. So finalizing that plan, getting your project leads together, figuring out who's gonna do what, and really start the plan. Training. In training, I can't say anything more than start early. To me, that term of the week thing is training. Start getting people immersed in the system. In our county, in our call center, we're going to train every single person in Medi-Cal. And I know I have one of my employees here. I think she's already Medi-Cal, though. Juliana, where are you? She may be in the other session. We're going to train, right now we have CalWorks, CalFresh, and Medi-Cal in our call center. We're going to train every single one in Medi-Cal so that everybody can answer some of those phone calls. So training early, getting ready early. And then the finish line. We're all going to get there, whether we want to be there or not, right? We're all going to get there. We're all already on that racetrack, and we're all going to finish. Even if we're going to finish slow, we're all going to finish. So this is my, my graphic of us all finishing. We're all going to get there one way or another. And I didn't intend it to be a big crash at the end, because we're not going to be a big crash and burn, but we all are going to get there. But in our county, just, you know, kind of plugging along, learn everything you can, start digging in now, just jump in and start doing it. And, you know, that we're just kind of running along with Kathy and like, okay, what next? Do we know the answer to that? So that's just what we're doing. It's not a whole lot of exact stuff now because we don't know a lot of answers yet. Okay? Thank you.
Our next panelist is from Riverside County Department of Public Social Services. This is Anna Martinez, who's the Assistant Director, Self-Sufficiency, Department of Public Social Services. Anna first joined Riverside County in the mid-1980s as a typist clerk 2, and during her 27 years at DPSS, she has worked her way through the ranks and held several positions within self-sufficiency, including eligibility technician, eligibility supervisor, appeals specialist, administrative hearings unit supervisor, and regional manager. In 2007, Anna changed assignments to the interim administrative manager for human resources. And in 2008, she was appointed executive director of the Public Authority in Adult Services. In July 2011, Anna returned home to the Self-Sufficiency Division after being appointed assistant director. Anna has extensive knowledge of self-sufficiency programs and is a proven leader within DPSS. In addition to her wide range of experience, Anna has a Bachelor of Science degree in Business Management, is a graduate of the University of Riverside, Gary Anderson School of Management for both Advanced Management and Executive Management programs. Anna.
Well, hi, everybody. Well, this is the week we celebrate at a national level eligibility workers. So happy Eligibility Workers Recognition Week to all of you. I think most of you in the room have either been eligibility technicians at one time or are currently eligibility technicians, and the work that you do is so important to the people that we service, and especially during these times when we're facing major, major changes. And I was an eligibility technician in the mid-1990s when we implemented welfare reform, and it felt like, you know, so many things were happening all at once, and we didn't know what we were going to do, how it was going to impact us. So it kind of feels that way again, and I think we're going to get through this just like we did before. It's just a matter of all of us working together and learning how to navigate through the changes and maintaining a positive attitude. There's not a whole lot we can do. As you heard from the other panelists, we don't have all the answers yet. We have a lot of questions, and we're asking questions, and we're going to do the best to prepare with the information that we have. So I have quite a few PowerPoint pages there, and I'm going to skip through several of them because they've already been covered. So we'll get started. Is the clicker somewhere? It should be right there. Oh, is this it? Okay. Let's see. Let me see if I have this the right way. Is this the right way? Okay. Okay, so what have we prepared for? Well, we're still that's still a work in progress. We began last year in January of 2012 with implementation of the low-income health plan. And in Riverside County, it's called the Riverside County Healthcare Program. We began enrolling people who were not eligible to Medi-Cal, and these are individuals who have no linkage and have excess resources to qualify for Medi-Cal. So in Riverside County, what this looks like, currently we have over 25,000 people enrolled in the program. We use 138% of the federal poverty level, and this will be the same population that is going to fold into Medi-Cal in 2014. So we're already beginning that expansion into healthcare reform. And we have a group of about 24 individuals housed at our Riverside Regional County Medical Center who are processing low-income health plan applications. And beginning in January of this year, we expanded that enrollment to all of our district offices. So what we started doing is we began evaluating every Medi-Cal application that we deny at our local district offices for low-income health plan. And that's when they're denied for excess resources or no linkage to Medi-Cal. So our eligibility technicians now, the district offices now, are putting cases on the low-income health plan or Riverside County health plan. And eventually these cases will be transitioning into Medi-Cal 2014. The other thing that we're working on right now is the Big Healthy Families transition into Medi-Cal. In Riverside, we estimate about 76,000 children are active on Healthy Families. And this is a group that we have to transition. In addition to that, we're anticipating 2,300 new applications a month for Healthy Families. And overall, Riverside County carries a 0.7% of the state's Healthy Families caseload. The transition will take place in 4 phases, and I think Kathy has covered this already. In Riverside, about half of our cases, Healthy Family transition cases, are in the first phase, and that's the current phase that we're working on. And Kathy spoke about the 2 options for Medi-Cal, the state-based approach and also the county-based approach. Healthcare reform impact on Riverside County. It's a new and innovative way to deliver Medi-Cal coverage to California residents that would not normally be eligible for Medi-Cal. So there are a lot of positive things about this expansion. The people that wouldn't otherwise get the healthcare coverage will be eligible. Kathy talked about the new MAGI, the different type of budgeting, contact with other counties and service providers, and new knowledge and skills for line staff. So we're moving toward just a different approach of determining eligibility. For Medi-Cal now, what we were used to doing is we take the application, verify, and establish eligibility. Under the new rules, we're going to take the application via different ways of getting the application. We're going to determine eligibility and verify later. So it's a whole different approach and different mindset than what we're used to. Some of the things we're doing locally is we're evaluating district office capacity. One of my colleagues here talked about telecommuting. We're piloting a project in our county right now for telecommuting, and we're actually considering expanding that because it's going quite well. So that's going to relieve some of the office space limitations that we have right now, and we're going to be allowing more staff to telecommute so that we can meet the demand and be able to hire more staff. We're also looking at our lobby management processes, and you'll hear this common theme that these are a lot of our counties are doing the same things. Looking at self-service options for customers, we're also piloting a kiosk where customers can come in and submit their verifications, get them imaged into the system, get an automatic receipt for them, wireless barcode readers for our lobbies. We also, in the past year, established a new business process standardization process in all of our offices so that customers can go into our different offices and have the same experience. We have a greeter in our lobbies. We have a triage station and an information window. So we're doing different things so that customers can be more easily serviced and also open up some self-service options as well. And those are the alternative service delivery methods and tools. And also, we're being proactive with our marketing efforts to mitigate service delivery issues, and that's going to be really important in the next year. We established a community outreach branch within our division, and we have a group of staff that are working very closely with community-based organizations and other agencies within the county to get the word out about the new things that are coming. We want to educate the public and hopefully minimize calls and office visits into our offices. So again, it changes both the culture and delivery of services for county welfare agencies. What we expect to see is increased traffic online by telephone and office visits. So we want to mitigate those as much as possible, and as I mentioned, be proactive. Many of the public will be seeking services, will be first-time visitors to our county welfare offices. They've never been in the system, so they don't know what to expect. They're going to have a lot of questions, and we're just going to be servicing a different population than what we've been used to servicing in the past. Our Medi-Cal caseloads, of course, are going to be higher, and we expect increased traffic between public assistance programs and low-income insurance programs. So as the circumstances in the households change, if their income decreases, they might come back onto our program, increases, that they might go into the low-income insurance programs and back and forth because things change in people's lives. So we expect a lot of that back and forth kind of traffic between low-income insurance programs and our Medi-Cal program. As we move forward, we want to continue to focus on our agency's core values. Important to focus on why we're here. We're here to service our customers. We're here to make our services accessible to our customers and continue to work on our public relations so that we can continue to be here of service to the public, educate both our staff and the public on the changes that are occurring in the next year or so. And again, we're moving to that no wrong door approach that my colleague spoke about. In the interface between Meds County and Covered California, how that's all going to work, we're still sorting through that and trying to get answers about how the systems are going to communicate with one another. Applicants can apply for healthcare benefits through any portal, through the state exchange, the county offices, by telephone, in person, and online. And we use the See For Yourself system for online applications. We talked about the customer call center contact warm handoff, and that's something that we're working toward in Riverside County. In fact, last Friday, we just launched a new enhanced call center technology in our county. So far, it's going very well. We're going to be adding more staff. We have Medi-Cal workers and CalFresh workers in our call center. I hear San Bernardino County is going to be training all of their workers on Medi-Cal. We may be doing the same thing. So just thinking about how we're going to integrate what we have in existence now with the expectation of the new requirements and what we need to do to enhance our services in the future. We're shifting again from determining eligibility for Medi-Cal to determine what a customer is eligible for. So it changes the customer service from our passive role to one where staff engage the family in getting coverage, and also the opportunity for that horizontal integration of services, and we're calling it CalFresh InReach. So ensuring that our customers that are applying for Medi-Cal services are also eligible for CalFresh, or the other way around, or determining whether somebody on CalFresh may potentially be eligible for Medi-Cal. So we've been doing that all along, but I think this kind of heightens that awareness that we need to continue to do that. We're aligning resources and continuing to hire more Medi-Cal staff to meet the demand. We're hiring Medi-Cal staff at all levels. As we bring in more line staff, we also need more supervisors, and we need more program specialists type folks so that they can help us sort through the new changes. We need more training staff. So we're looking at the whole organization as we hire more staff. And we're also looking at support staff. Office support staff is equally as important because they're the ones that do the file clearances and the research needed to establish these cases. And continue our communication, both internal and external. Sharing of information with staff. Last month rather, we had a forum with supervisors and managers in our department to inform them of the legislative changes that are coming up. And again, we put it out there. We don't have all the answers, but we wanted to get out as much information as we had so that everybody has at least some information of what is coming, so that we're not caught by surprise. So as information becomes available, we continue to share the information. And we're going to be sending out a newsletter, starting a new newsletter with information about changes that are coming with healthcare reform. We continue to develop policies and procedures, and we meet frequently with our training, with our staff development folks, so that we can be prepared to deliver training for staff once we have all the information that we need to do that. With the Healthy Families transition, by the end of 2013, we would have had almost 93,000, or rather 92,281 customers transition into Medi-Cal. Some of the applications need to be processed within 10 days, so we're flagging those applications. What we've done in the last month, we made a decision to centralize the file clearance and the pending responsibilities for the new Healthy Families applications that are coming to us. So we have a team of office support staff that are doing the research and the pending of these applications. And we have another group of 5 office support staff that are doing the imaging, and these cases are getting electronically assigned to eligibility technicians all throughout the county based on zip code. So we centralize the intake piece as far as the file clearance and pending, but the processing of these applications is decentralized. And we're going to continue to monitor this process and adjust it as needed. The community engagement is going to be a very important piece of healthcare reform. I mentioned our community outreach branch. We're working closely with public health, mental health, community hospitals, and community-based organizations to help as sisters, so that we're going to use them as referral sources and to help us educate the public on what's available to them. And hopefully also to take applications for us and help us with what verification process is needed. We're hoping that by utilizing these resources, we will alleviate some of the workload on our staff and continue to just get the word out to the community and to the public. And this concludes the end of my presentation. Again, we're just doing the best with the resources that we have, continuing with a positive attitude about these changes, and doing the best that we can to keep everybody informed, to get the communication going, and we're open to any questions as we get them. We're sending them on to Kathy, to the state, and waiting for some answers. So thank you, everyone.
Thank you, Anna. Our final panelist for this afternoon is Roxana Molina. She is the chief of the Medi-Cal and IHSS Program Division for the Los Angeles County Department of Social Services. She has been with LADPSS for the last 21 years, starting as an eligibility worker for Medi-Cal and food stamps. That was even back before CalFresh. I was there too. There's a few of us left. She was promoted to Division Chief of Medi-Cal and IHSS a little over a month and a half ago. Prior to that assignment, she was the director of the Customer Service Center and oversaw the rollout of bringing all the district offices into that customer call center. She has been the director of the Pasadena and San Fernando offices for 3 years, overseeing CalWorks, GR, Medi-Cal, and CalFresh. For 4 years, she was a track manager at the Eligibility Services Division and was responsible for Medi-Cal EDBC. She spent 5 years before that as a Medi-Cal analyst in the Medi-Cal program. Welcome, Roxana Molina.
Thank you. I don't have a slide. I think you guys have glazed over already with the slide showed. And basically, the challenges that LA County is facing are exactly the same that every other county, every other consortia, and everyone has already discussed. But I do want to give out a few things that LA County is doing. And just give you numbers, because everybody talks about the size of LA. We like to call it the state of LA. So yeah, the monster that we are. So just to put it into perspective, everybody's talked about Healthy Way LA. I'm sorry, the LIP program. In LA County, we call it Healthy Way LA. Currently, our numbers are 233,000 have been enrolled. In comparison to the other ones, you just see just how huge we are. Related to the Healthy Families transition, we are expecting to see anywhere between 3,000 to 5,000 new applications monthly coming in. Currently, we are expected to receive a little over 200,000 children transition over to LA County. The one good thing we've identified that about 75% of those children, we already currently have a case where the family is Medi-Cal eligible or the child is already Medi-Cal eligible. So we have those numbers. In LA County, our Medi-Cal caseload is about 1.2 million cases, okay? What we expect to see with the healthcare reform is starting with at least an 18% increase in our caseload, just in this fiscal year given to healthy families. So you can just imagine those numbers. We currently operate 36 district offices throughout LA County, anywhere from the border cities or the border offices in Pomona with San Bernardino, Lancaster with Kern County, Norwalk with Orange County, and we have also our West Valley with Ventura County. So we pretty much border every county that you guys probably live in. So one of the things, because as everyone has explained or discussed, healthcare reform is a big animal to tackle, especially to LA, given our size, our population, the population we service. What we have done in LA County is we have definitely started in various committees. We have healthcare reform steering committees, not only internal within our own department, ensuring that every piece of our DPSS operation, our Bureau of Administrative Services, which is our budgets people, are there. We also talk to the bureau that oversees our properties. We're talking about our Human Resources Division, our Bureau of Workforce Services, which is will be considered the line operations where all the eligibility workers and eligibility supervisors are at. So all of the bureaus, all of the key players meet every 2 weeks. This is how important it is to us. We have a standing every 2 weeks healthcare reform steering committee. In addition, prior to coming here, we are now meeting with our Board of Supervisors. They have created a healthcare reform task force that is being led by the CEO, and not only my department, but also ISD, our various other departments, including the Department of Health Services, Department of Mental Health, are coming and meeting monthly to discuss the operation, the processing, the integration, everything you can think of related to healthcare reform. So as you can see, it's not just at our level. We have totally brought in, because of the size of our department or our county. So one of the things that we've identified and we're trying to target them is the Healthy Way LA LIP, Healthy Way LA transition. Our target, because we do have a mandate, is to have 300,000 individuals enrolled by the end of this year. So with that said, what we've done is we are now collaborating with our Department of Health Services, and we are now also assisting them in the redetermination process. So DPSS has taken on that additional workload to assist our DHS partners. And with that, part of the things we're looking at is claiming, for this workload. We're also looking at the Medi-Cal expansion when it becomes part of healthcare reform. What we've started, in addition to the internal healthcare reform steering committee, we just started, I think it was the first one, with our union, our SEIU. We are now also meeting with them. I want to say, I'm not perfectly confident about whether we're going to be meeting monthly or every other month, but I know that discussion with the union has already started, because like everyone else has said, you guys are critical to the success of this whole transition into healthcare reform. LA County currently has 3 customer service centers. I was the director over 2 of them, and just when I left, they got 2 people to see. So, but we have 3 customer service centers. One is in El Monte, one is in Northridge, and one is in our, what we call La Cienega, which is by the airport. Each one of them has approximately 150 employees. I know the Northridge one is a bigger facility, and they have a little over 200. Currently, we are supporting 22 of our 36 district offices, and the current approved caseload that we're supporting is over 900,000 cases. Just so you know, they answer all programs. For LA County, our staff answer all programs: Medi-Cal, CalFresh, GR, and CalWorks. We have peak times like anyone else, the first week of every month, the Tuesday after a holiday, and the Monday after the weekend. I mean, that is, I think across the board, everybody sees that. Our favorite time, of course, for us is cycle 1, QR7s. So we're in the same boat. We average for us, and we have, because we are so big, because we have 3 huge customer service centers, our automation and our link to CalHears is critical. So our eligibility systems division, or our automated system leader, our counterparts, they have been very much involved in the whole CalHears conference calls. I know Kathy, because they're going to be critical to the whole interface process. And they're an amazing group of people that I bless them every day. I thank them, because just like, it was said that some of the meetings you hear, you lose it. I mean, I try to listen, but half of what they're saying, I glazed over, and I have no idea what they're trying to agree on. I'm just hoping that they all understand and they agree with that. We're going to get the right route. But, what we have to look at, one of the things they talked about was the availability that's going to change related to CalHears, and when staff need to be available, the change in hours, when we need to be there. And I think those are critical pieces that we already started talking to our union, because our staff need to be aware. In trying to get ready for this, staffing is an issue for us, given not only to support the customer service center, which is going to need additional staffing. We're talking about additional staffing in our district offices like it was identified. We will have individuals walking into our district offices. Now, the commitment in my department is that we don't want additional buildings. We do not want a new building. DPSS in LA County is adamant that we will not buy, rent, lease another building. We have looked at every available space pocket in every one of our buildings to try to fill in. We've also looked at, we currently have a couple of pilots in the telework and hoteling. How many of you have heard the term hoteling? Not many. Hoteling basically is sharing workspace. That's what we're trying to do, so that, like everybody said, you may be able to do some work from home. Kathy and I can share the same cubicle. We'll just swap it on the days that I come to work on Monday and Wednesday, let's say. She's working from home. She'll come to work Tuesday and Thursdays, and we'll see how that. So we're looking at all these different alternates as to how we can accommodate this additional staff influx that's going to come in. without having to get additional buildings. Our department is also very much committed into minimizing lobby traffic. They're really pushing for automation. They're pushing for online application. They're pushing for having the participants, and that's what we call them in DPSS LA, you know, call from home, apply from any other facility that they have access to a computer, but we want to really minimize lobby traffic. That's our intent. We don't want participants coming in. We know there are going to be some, but we want to minimize it. So that's our goal. With that, we're working very closely to see, again, space pockets within our own department, as well as we're also looking at, can we start having staff work out of different facilities? Not ours, but could be DHS, could be a WIC facility. I mean, we already have outreach workers that do that, but expand it to have additional workers. Go to other facilities where there may be space. That was one of the discussions we had earlier today with the CEO. It was, can ISD identify where there's space available that we can put staff and have them take applications or process applications? So we're really, you know, we have a wonderful director who is always very, you know, she's always really thinking outside the box. She's always telling us, don't think of how we do business. How can we do better business? What else can we do? Always think outside the box. If you tell her, I can't do it, she doesn't want to hear it. She wants to hear, okay, we can't do it this way. What do you need to get it done another way? So she's very proactive and always enhancing what we have in automation. She really, really believes in automation. So if you see me with my little iPad, that's a whole new thing for all of us. We went from a BlackBerry to an iPad. I don't know which, I think of them as my little LoJacks because they always know where I'm at. But that's her whole thing, you know, let's use the automation that's out there to do a new way of doing business that's the best for our own workforce, but at the same time, the end result is how do we service the participants quicker, faster, better. So I just wanted to, that was like my whole thing, just give you an idea of what LA County is challenged with, because basically it's the exact same thing everyone has already spoken to. It's just multiplied by 30. You know, that's our reality. We have a workforce of over 8,000 eligibility workers. You put it all together, we're over 10,000 in DPSS. So we are definitely, I mean, we are the state of LA. That's who we are. And so when we get the numbers, you know, they're coming over, it gives you an idea as to, yes, you guys are being challenged with what you have. Every county is, every department is. I think that June said it best as to this is a perfect example as to for everyone to understand and fully grasp that we have to do certain things that are not at our request because we didn't wake up and say, well, healthcare reform, let's think of that one. It always comes down from the state, from the feds, and these are things we have to put in place, you know, but this is one of those times where we're really working closely. I've never seen it, and I've been with the county now 21 years. This has been my career right out of college. This is what I've done. And this is the first time that I see every one of our bureaus, sections, divisions so overworked and stretched to the breaking point, it feels like. But they're doing an amazing job. Just when we didn't think we can do something, it gets done. And I'm going to tell you, I'm going to root for my little eligibility systems division, which is our leader section, our consortia, that have been working and stretching because they're touching everything. On top of everything that we have here, we're going through what we call our LRS, which is our leader replacement system. We finally got both state and board approval. So not only do we have to deal with everything coming down the pike on healthcare reform, we're creating a whole new eligibility system on top of that. So imagine what, you know, everything that's happening in LA County. So pray for us. Thank you.
Thank you, Roxana. One thing before the questions and answers, they tell me that all of the handouts from today's panel we're hoping to have those available for anybody who didn't get them, or if anybody else in your agency would like to see them. We hope to have those up on the new website within a couple of weeks. So that should be available to everybody there. We've got about 10 minutes left here for some questions and answers for our panel. We've got these mics live now, and John will come around with the mobile mic. So who has a question for the panel? Oh, yeah. Who wants to go first over here? Of course. Get your exercise, John.
System to handle the influx of, new applications and all that. Has there been any talk about developing or creating an automated system? I know we already have like the work number to verify income, but we need a better system for verifying income, because a lot of times we get payment reports and things late, and we don't have income liaisons with like the employment development department, and sometimes there's a discrepancy between meds and C4, and so we need, has there been any talk about an income verification system that populates so we can get that verification when we need it before it's too late and we have to do?
I can hop in on this one. Yeah, the answer is yes. So I think that's probably good news, and I apologize for not touching on that. There's two things to mention about that. It's a really good question. First is that the federal government is supposed to create a data verification hub, so that on an electronic basis, we will be able to more easily verify income, citizenship, and identity using probably not tapping directly into databases that those federal agencies like the IRS or the Immigration Service run, but they'll probably, I think, create some kind of a data warehouse to house that information that they will update regularly. And then when someone comes in and provides some key pieces of information, we'll be able to use that data to call out to that hub and then come back. And there's been talk about trying to do something similar at the state level, though I'm not sure if it would be on the same time frame. The other thing to know that I didn't mention, but that's important and a change for your work and your colleagues' work, is I know today with the reports that you do get, there are thresholds. For example, with the Eves report, if there's a discrepancy of over a certain dollar amount, that's when you would work that. The standard is supposed to be one of what they call reasonable compatibility. And while that's still being fully defined, I know that's shocking, the gist of it is if it's not a big enough discrepancy to make someone ineligible, then you can largely ignore it. And so that could be, I think, raises hopefully those thresholds to a higher level before you would have to actually take action when you see that there is a discrepancy of a relatively small amount that wouldn't actually have a material impact on someone's eligibility for the program.
Okay, next question. Over here.
Hi, you had mentioned that there was going to be, an open enrollment period, and I was wondering what would happen when we would have people that were in the Medi-Cal program and their income increased and it wasn't an open enrollment period.
That would be one of those qualifying life events where they would be able to move into the exchange. So getting a job where you didn't have one, or losing a job and going in the other direction, or having some significant change. My understanding is losing Medi-Cal eligibility would be considered a big enough event in your life that you would still be able to go then move into the exchange. One of the things that we're hoping is that the reporting of income and acting on those changes could be less often as well, hoping that for example, in eliminating the mid-year status reports, that we won't have to be rerunning eligibility in between times as often. Some of that is state option, and some of that is federal rules. And so how the state decides how often it wants to check in and ask people to check in, we of course would argue for the less is better. So.
The gentleman right here, and we'll come over here.
Let me say, first of all, that I think you all did a great job in your presentations, and if everybody can give them a hand, I'm sure they'd appreciate it, the time taken out. With that, I got 2 questions, so bear with me. The first question is, with the several steps that have not been given a target date for implementation, can that be construed as possibly the state looking to outsource or privatize the application intake processing of Medi-Cal?
So no, and that's good news. There's no move on the part of the state, and in fact, the administration has repeatedly reaffirmed, as recently as January 10th, when they sent the budget out, that counties do Medi-Cal eligibility. There's no move to privatize that. I know we did see that, and together, many of you worked with us in the prior administration to fend those efforts off. There had been a discussion with the Exchange Board as to whether they might hire private sector staff to run some of their piece of the world. And the decision was made after a lot of discussion to not do that, to hire a combination of state workers and county workers to do things like run their service center, that state. Those 2 state-level service centers that I mentioned, those will be state staff. They will not be private sector staff. And then the third one, like I said, is a county staff. So
that's great news.
Yeah.
Great news. My next question, will MEDS remain as it is today as the only statewide system that displays recipients' Medi-Cal coverage? As we all know, MEDS is pretty old, antiquated, and whatnot. So does the state have plans to update it or bring in a whole new system? Thank you.
Yeah, I will say I do have a recurring nightmare where I wake up in a cold sweat, and the nightmare was that MEDS has crashed, and they've called me. See, it all comes to me, right? And said, what are we, you need to tell the counties at 3 in the morning that MEDS has crashed. It really is baling wire and duct tape, a lot of it right now. Unfortunately, it's just such an old system. Yes, the plan, my understanding is the plan is to modernize MEDS over the course of the next several years, so nothing happens overnight in the IT world. As Roxana just mentioned, this leader replacement system has been in the works for years, and it finally just got all the necessary approvals to get started within the last, 6 months. And so it will take some time, but my understanding is that the state does plan to modernize MEDS, and I agree that it very much needs that. We've been trying to help them look for opportunities, because we know it, when you and your colleagues make changes to a case, for example, and it doesn't take, and you don't find out till the next day, and then you have to do it again. I mean, it's just, that's that real time concept that we're trying to get into with all of these changes isn't really supported by how MEDS is currently structured, so. Stay tuned. Thoughts?
Can I make a quick comment?
Yeah, hold on, Randy.
Just so we take the burden off of Kathy entirely, but I think this is actually diagnostic of what's going on. Is we counties are sort of waiting, and there's a lot of stuff that Kathy works on. But I just wanted to respond to your first question a little bit, which is this issue of privatization kind of comes and goes, and there's a national dialogue about privatization and anti-government. And I just wanted to add to what Kathy said, that this healthcare reform transition is probably going to be a 2, 3, 4, 5-year effort. And I just think we should just keep very diligent about proving our worth constantly. I think people are quick to judge what we do, and they take the exception when we make a mistake as the example, and we don't highlight the great work we do a lot. And I just think we should all at every level be mindful that that question will probably be looming for a few years, and I say that as an empowering statement. There will be lots of opportunities to gravitate towards this is impossible and too difficult, or no, I'm going to step up and provide great service. And I think collectively, the more we do the latter, the less likely that privatization question will kind of get more legs. So I don't, yes, January something happened, but there's a yearly cycle.
That's a great point. And a glass half full point.
Earlier, you touched on the state call center performing the warm transfer, option 1, or the partial transfer, partial assessment, option 2. But back in September, we were fighting the issue of a full assessment, option 3. And I didn't hear you mention that during your discussion. So is that off the table?
So, Robert follows this stuff very closely, I just want to say. So to catch up folks a little, and I debated how much detail to go into, so thank you for the question. The exchange staff and exchange board, the Covered California Board, and the administration have to decide certain things about where you draw the line about how much they over at the exchange do what looks like or could turn into Medi-Cal. You don't know when someone first calls if they're Medi-Cal or not, right? You have to figure that out somehow. And so this was the debate, well, how much work do you do to get that caller down a path before you say, whoops, these guys are Medi-Cal, that's a county role. And so we were able to get them in September to affirm, yes, the counties are going to do Medi-Cal. That is an agreement and a principle that the administration stands by. And so now how do we actually make that work when you've got a caller on the line and you've got the exchange center, service center representative on the other? And that's where these 6 questions and that quick sort that I showed you come into play. So the question becomes, what do you do with those 6 data elements, and how do you make the decision of which cases look Medi-Cal and which ones do not? Some of it is still up in the air. I'm sure you're shocked to hear me say that. For cases that are clearly only Medi-Cal, only people in a case who are Medi-Cal based on those 6 questions, those would come to the county. After those 6 questions, no further assessment would be done of the case at the exchange level, and just those 6 questions would have been asked, which are not considered to be an application. It's just that quick sorting mechanism. If it's clear that nobody in this case is potentially Medi-Cal or very, very unlikely, that would stay at the exchange. And what you've got in the middle are what we've been referring to as multiple program families or mixed cases. Think about, even in this new world, you're going to have children potentially who today are eligible at a higher federal poverty level than their parents. And so if you know that the person calling is a mom, and mom's got a husband and 2 kids, well, the kids might be Medi-Cal eligible, the mom might be exchange eligible along with her husband. And so do you default that to the Medi-Cal and have the county process that case, or do you default that to the exchange and have the exchange process that case? We've argued, we've been working with SEIU very closely, the 2-1 locals, to talk about the need for that to default to counties and have counties do the Medi-Cal first, rule it out for the parents, and then help them do the exchange eligibility. Exchange board staff are very clear that they would like to retain that case, work the exchange eligibility first, but the concern is you can't, the way our computer systems work, you can't run the eligibility for just the parents, you're gonna do it for the whole family. So really you're ruling out Medi-Cal, signing the kids up for Medi-Cal and doing the exchange when you run EDBC for that whole family. And so we don't like that. We want it to go to the counties. Where it's sort of gravitated to is the idea that for the first open enrollment period only, given that the stakes are high for the exchange, they think that the vast majority of their calls will be exchange cases. They would like to have a deal where they would keep the case and work that for the first 6 months. They would not do final eligibility determination for Medi-Cal. That would still be passed to the counties, but they would have done the bulk of the work for those cases, but that would only be for the first 6 months, and then it would revert to the default would be any Medi-Cal in a case would go to the counties. There's going to be, this was supposed to have been presented at, I don't know where to start. Okay, I could keep talking on this for like 20 minutes, but let me say, we're not thrilled with that at CWDA. That's not a deal that we cut. I think that we think that the principle that you do Medi-Cal first and that counties do Medi-Cal should apply here. We understand that everything's a negotiation, that sometimes things are negotiated in a way that you don't like by people who have the final decision-making authority, and that's not us. And so to the extent that there is a deal negotiated between the administration and the exchange that would allow this to be done for the first 6 months, we'd want it to be codified and make sure that it is by codified, I mean like put in state law, and made very clear that it is only for that first open enrollment period and then never again. And then, and reaffirming that counties do Medi-Cal eligibility. Again, not that we like the deal, but if you're gonna do it, then do it, you know, so it's only this one time. And make it clear that you reaffirm that. So just to say, the Exchange Board was supposed to actually discuss this at their meeting last Thursday. I was prepared to say a minute's worth of that, condensing all of what I just said into 60 seconds, which is fun. But they did not get to it. They ran out of time. And so they're supposed to do a webinar on the 31st, next week. This is, there was an email that I just received, and it's probably on their website, where they present this. And I don't know if it will be the exact same presentation that I've seen and discussed with them, or that they made public, but if it is, it would make this proposal for those multiple program families. What it would stop short of doing is saying this is only one time, that this is only for the first 6 months. It has a bit of an asterisk there and says the intent is for the first 6 months, and then we have to kind of reassess. So stay tuned, I guess, Robert, would be the short answer. Is this is clearly, this is not the bulk of cases. I want to make clear. I think, you know, the numbers that we see from the exchange are more will be either Medi-Cal or exchange than both. But we know how parents and children end up in the same family. So whether those data and projections are quite correct, I think we need to take a look at, and then continue to work together to say Medi-Cal is important. You have to do Medi-Cal first by federal law. And so what does that mean when you have a family that could have both? So that was a really long answer to your question, and one of the reasons you see why I didn't put any slides in about it, but I'm glad that you asked because I know it's important. So.
Okay, thank you. We're up against a hard deadline in the room here, so we're going to wrap it up. I want to thank you all for both your attendance and your participation this afternoon. Lots of great information. We want to thank our panelists again. We're going to, don't forget your evaluations. We appreciate having those so we know what to do from year to year. Remember, at 5:30, we have the President's Reception. We also have the Eligibility Expert Game. And so we need to get out of this room. They're telling me, get these people out of here. Hey, we'll see you back around 5:30.